started because we have several different chapters and a lot of material to cover this time. All right, so the concepts we're going to go through include mobility, fitness, physical activity, and exercise. So I'm not going to spend too much time going through this because we all know what these things are, but mobility is just the body movement. Physical fitness or fitness is our ability to carry out daily activity, daily activities of daily living, and without things like excessive fatigue or things like that. So you can recreate and do the important things, respond to emergencies if needed. Then the physical activity is just the movement produced by contraction of the skeletal muscles, and that increases energy expenditure. And so that's just what you would expect, and we assess that based on different levels. And then exercise is a subconcept of physical activity, which is really just that it's planned activity, it's structured, often repetitive, and with the idea of improvement over time. So the physiology of movement, we have the skeletal system, and this includes, as you know from anatomy, our bones, cartilage, ligaments, tendons. It forms the framework of our body, and there's a couple different aspects to it we're going to talk about. So the first one is osteoclasts. So these are specialized cells that are housekeepers of the bone. Okay, they could break down old damaged tissue. And osteoblasts, so clast means breakdown, blast means repair, right? So they can repair damaged bone and build new bone to keep the skeleton strong. So a delicate balance between the actions of the osteoblasts and osteoclasts form together to make our system work, right? When two bones come together, and they articulate, then a joint is formed, right? And we're going to talk a little bit about that now. So synth arthrosis, those are immovable joints. So for instance, the bones of the cranial vault, those are immovable, and they have some flexibility, especially when you're a baby, but ultimately they're not meant to be much more than rigid. We have amphiarthrosis, and these are joints that allow limited movement. Some examples of that would be the vertebrae or pubic bones, and there is some flex there. Diarthrosis or synovial joints are freely movable because the amount of space in between the bones. So you'll probably heard of synovial fluid. And so examples of this would be connective tissue in the joints and skeleton. The fluid and articular cartilage prevents friction. So, we heard of the meniscus and things like that. Those are the types of things we're talking about. And then muscles, this is, we describe these because they're attached to the bone at 2 points. Number one, it has a point of origin and it has a point of insertion, right? You can see the tricep and bicep up there. And so there's always a point of insertion and of origin. And that's important because one of them is, both of them create the angle that the joint will move, right? So the belly of the muscle is the biggest part that lies in the middle of the 2 points, all right? The muscles work in pairs, right? So you have a biceps brachii contracts with the flex of the forearm, and that makes it bend at the elbow joint. And when the bicep contracts, the opposite muscle, the triceps brachii, relaxes. So those two muscles work together. And the nervous system, this controls, and this is the motor nervous system, this controls the movement of our musculoskeletal system. Okay. So these are either autonomic or somatic. The autonomic nervous system, of course, consists of sympathetic and parasympathetic nervous systems. And so these systems innervate certain muscles. They're involuntary, such as like the heart, blood vessels, and glands. All right. And then the somatic nervous system innervates the voluntary skeletal muscles. So When you decide you're going to bend a joint, the thought originates in your motor area of the cerebral cortex. The upper motor efferent nerves communicate with the lower motor neurons that conduct impulses to the muscles. Okay. When this muscle receives the stimuli, it contracts and relaxes, whatever the situation may be. Okay, so you hear people talk about body alignment or body mechanics. So, body mechanics is a general way to describe the four components, which is body alignment, balance, coordination, and joint mobility. We're going to go through this. Body alignment is your posture, and it places the spine in a neutral resting position. I'm going to readjust my posture while we're talking about this. And proper posture is essential because it creates a healthy curve in the spine. And we're going to go through that in a few moments. But what you want to have with a proper posture is your spine is in a natural position so that it limits the stress and fatigue with muscles and joints and ligaments. This is one of the things that can contribute to back pain or neck pain. I have neck pain that I deal with almost every day, and that's my posture and sitting in front of a computer a lot can exacerbate it. So I have certain things that I do to help with that. Okay. So when your body's in alignment, it achieves balance. And what we're talking about with that is that a line of gravity you can see up here is it's an imaginary vertical line drawn from the top of the head through the center of gravity, the middle of your body, not only in the middle, but inside the middle, right? And so the center of gravity is the point around where the mass is distributed. So the center of gravity is actually below our umbilicus. It's at the top of our pelvis. Okay. And the feet support our base of support, obviously. And the broader the base of support, the lower the center of gravity, right? You spread your legs out for a sumo squat. That squat is going to be naturally lower. And it's easier to maintain balance. Okay. Coordination, messed it up. Coordination is all it really is smooth movement requiring coordination between the nervous system and musculoskeletal system. Okay. So some of the things that happen in the nervous system includes the cerebral cortex initiates the voluntary movement on this. And then the cerebellum coordinates the movements for things like proprioception, okay, where awareness of posture, movement, position sense, okay. And then the basal ganglia located deep in the cerebrum assist with the coordination of movement. All right. Damage to the motor cortex, cerebellum, or any of the basal ganglia will affect your coordination, right? So, for instance, a stroke can affect your gait or in your posture. And then I keep doing that. And then joint mobility is something that you'll see discussed throughout the next few chapters. But what it is the joint movement allows us to do all the things that we take for granted, like range of motion. And so that's the movement of a joint performed without assistance. That's an active range of motion. And then passive range of motion, which you'll see in the hospital, is something where we move it for them, either through a machine or through physical therapy, things like that. All right, so body mechanics. To avoid injury, you're going to use proper alignment, keep that wide base, avoid bending and twisting, squat to lift. We've probably all heard this. If you've ever had a job, they most likely trained you on this. But these are some good practices to help your patients avoid injury, particularly when they're in a compromised state. And by the way, this is important for us as nurses as well, to understand how to protect ourselves, right? So using proper alignment, have a wide base, avoid bending and twisting, squat to lift, keep objects close when lifting, raise beds, pull versus lift and get help. So these are all things that we can do to prevent our own injuries. And yeah, so I would advise you to stick to that. Okay, so isometric exercises are those that involve contraction without motion. So, for instance, it's against an immovable object, right? So you could go and push against the wall, or you can have maybe one. I'm trying to think of what an isometric would be. Maybe doing handstands, for instance, right? Something like that. So um, every time you do that, you would do it for a series of seconds. And when patients are bedbound, they can use isometric exercises, right, to maintain strength. So might just be putting your feet on the bed and lifting your hips against that immovable object, or it might just be putting some pressure on your heels in order to work those muscles. Okay. Then we have isotonic exercise. This involves movement of the joint during muscle contraction. So an example of this is weight training. Okay. Calisthenics, push-ups, and all that kind of stuff. This is obviously something we do when we're healthy. We take it for granted a little bit, but this, if the patient's comfortable, can do these, and they're excellent if you can do those ideally. And then we have isokinetic. This is sort of specialized. All right, this is provides resistance to movement. So exercise combines the features of both isometrics and isotonic. And so what ends up happening is you can provide resistance at a constant speed while the muscle is going through a range of motion. So health clubs and physical therapy departments are usually using this type of thing. And then we have aerobic exercise. This is anything that is a longer period of time, doesn't use the immediate oxygen debt. And so it's more of a long-term, things like jogging, slow jog, or maybe hiking, things like that. Okay. Something though, like a playing basketball or racquetball, or really high intensity interval training, right? CrossFit, all that stuff. All that stuff is highly anaerobic because you have oxygen debt. So your body burns energy differently, and it can help you. Like, for instance, sprinting is one, so that it can help you achieve a higher level of fitness. And this is for people that are pretty healthy, right? And young usually. I don't need to tell you the benefits of exercise, but it does improve the heart, right? The pumping action of the heart, the circulation, the venous return, blood volume. So all of those things. And then, of course, your cholesterol can be affected by that. From a respiratory point of view, it helps your pulmonary circulation, the gas exchange, and then it dilates your bronchioles. It helps you ventilate. Musculoskeletally, it helps skeletal development in children, particularly. It can help you gain muscle mass and strength, power, flexibility, coordination. So those are all things that it does. It increases bone mass. It can help you with your gait, your stability over time. With osteoporosis, it can help you maintain bone mass. It decreases your risk of falls for elderly patients, and reduces the risk of osteoarthritis. Oops. From a nervous system standpoint, it can help improve your nerve transmissions, helps your reaction time, and then your sympathetic response to exercise. From an endocrine point of view, it helps your sensitivity to insulin, and helps guard against metabolic disorder, things like heavy adipose tissue around the organs of the abdomen, things like that. It can help your gastrointestinal system by helping your appetite. It also can help your core, and then it decreases your risk of colon cancer as well. The urinary system, it helps the efficiency of your kidneys. And then your integumentary system, your skin tone has an improvement with improved circulation. So obviously that can be a big part of it. Your immune system decreases systemic inflammation, and it also helps you fight off bugs. Mental health, I think we all understand the benefit that might be the greatest from exercise is mental health, right? Helping with your self-esteem and your energy level. And it's a great way to relieve the symptoms of anxiety and depression without medicine. Okay. So overall health, anytime that you can reduce the amount of insulin that's in your blood, reduce the amount of sugar, and then also your caloric expenditure, it's going to help your sleep, and your body is able to run better on it when you don't you're not obese and things like that. So that's the ideal situation. You'll have patients that obviously are dealing with many of these issues, and so but this is the ideal, and this is the benefits of all of those things. You'll use that in education. Okay, so an exercise program is going to include these different things. So flexibility is important, right? So we want to stretch before we're going to do stretch before and after when we're going to do any kind of exercise. The resistant training is depending on which one you're going to do. You're going to do exercising for strength, which means you're going to increase the amount of resistance for each exercise to lift more weight, and then or you're going to exercise for endurance, in which case you would go longer, and you're going to increase the number of repetitions. Okay. And aerobic conditioning is just essentially components of the conditioning, including intensity, duration. Okay. These are things that we all do when we're trying to get in shape or we're trying to start spring training or whatever we're going to do. Okay. Okay. So the benefits of exercise, it can lower your risk for death. All of these same things as we talked about earlier, and then the risks for all of these injuries as well. Okay, so what are the factors that can affect mobility and activity? So first of all, developmental stage. We've talked about this with other topics. Depending on somebody's stage, they may be more capable than others in order to maintain this status, right? If you have a stroke and you're having receptive aphasia, for instance, it's going to be very difficult for you to maintain those types of daily living situations because you can't understand the information that's being processed. As far as nutrition, obviously that if you're obese and you're not able to exercise, or you have issues with nutrition and that led to diabetes, or maybe you're malnourished, these are things that will affect your ability to be mobile as well. Your lifestyle, if you are the type of person that doom scrolls 12 hours a day and has each hand on some French fries or something like that, then that's not going to end well. We all know that sometimes we engage in that, but we can't do that all the time. Otherwise, that's ultimately where we'll find ourselves with chronic diseases and with a difficult health profile. And then there's environmental factors. So this would be people that live in Seattle, for instance, when it's really rainy, right? There's a higher rate of depression in Seattle. Why is that? My assertion would be that it rains a lot and it's difficult for them to be outside and get sunlight. If you live in a place with pollution or with a lot of crime, that can be another thing. And then also finances. If you don't have the access to some sort of a fitness facility, you can always go out there and run, but ultimately some of those other factors might be a situation too. And then a support system. If you're not supported in one way or another, or maybe your home life has a lot of problems, then you're not going to be charged up for those types of things most of the time. Okay, let's talk about musculoskeletal skin system disorders. So these are diseases or abnormalities in the various body systems, and these can influence our balance, our body alignment, our gait, and our joint mobility. Okay, and so these will be diseases related to bone formation and metabolism. They can affect problems with bone integrity. Sometimes trauma can cause that. And then disorders of the nervous system, as we talked about. Okay, so a nursing history is going to be focused on the activity and exercise, and it usually addresses the usual activity, the fitness goals, mobility problems, underlying health situations like we just talked about, lifestyle and external factors. We're going to do a focused physical assessment. So we're going to take a look at what look at their vital signs, their exercise history, their height, weight, their BMI, their body alignment. You can take a look at the way they're standing. If they're sitting in front of you and they're constantly shifting and they're moving their neck down and things like that, they might have some of those issues with neck or back pain. So you can ask those questions as you see that in your assessment. When you have them raise their shoulders, for instance, if they one side doesn't have any strength, then you can notice that and start to pay attention to what that's caused by and what you need to plan for. Okay. Um, Before beginning your exam, just make sure that you're fully aware of the mobility status. You don't want to go in there and start moving people's limbs around and then find out they have a joint problem, right? I've done it, but so you just want to ask them before you do. You don't want to cause them pain or further injury. Okay, so here's some nursing diagnosis. Okay, activity intolerance. So this is something you've probably never said, but it's a state where the patient has insufficient energy, either physically or psychologically, to carry out the daily activities. Okay, doesn't necessarily say why. It's just an activity intolerance. Impaired physical mobility. This is some sort of limitation. Okay. Of independent movement in the patient. Risk for disuse. I've never used this one before, but it exists when a patient is prescribed or unavoidable inactivity creates the risk of deterioration of other systems. Okay. And then finally, sedentary lifestyle. We don't know what that is. It's just a habit of life characterized by a low activity level. So when we're planning, we're going to be thinking about the outcomes, right, and the evaluation. So we're going to look at our mobility diagnosis and our energy maintenance when we're thinking about this. How do we accommodate what their needs are and what they're likely to do? And how do we support their mobility? Because ultimately, we want them to be successful, and they're not going to be successful if we haven't planned according to where they're at. And then their mobility can affect lots of other things too. So we just try to make sure that we accommodate whatever we can do to help them in our discharge planning. All right, so the following interventions for the client who's immobile, the nurse will give a priority to A, encouraging a diet high in fiber and extra fluids, B, administering the PRN medication for sleep, C, having the client use the incentive spirometer every 2 hours, or D, massaging the client's legs every hour. Okay. Now this is one of those situations where it's probably a better answer than some, but there may be more than one, right? So what's definitely not the right answer? So client who's immobile, we're going to give a priority to massaging the client's legs, having the client use incentive spirometer, administering the PRN medication for sleep, encouraging a diet high in fiber and extra fluids. Well, I'm just going to give you one of these answers. I don't think it's B, and I haven't looked at this yet, but I don't think it's B because you're not going to be giving pain medicine for sleep necessarily because that's going to make them less mobile. But let's wait and see. Let's see what the situation is. Okay, so it's going to be C. So the incentive spirometer, and you might be surprised by that. Well, one of the things that's the most serious causes in that situation, especially more short term, is atelectasis. So this is the little bubbles inside the lung, those bubbles get collapsed and it can ultimately cause pneumonia. And it definitely decreases your oxygen exchange and your overall ventilation. Okay, so if you're going to plan something, promote some fitness, you're going to plan an exercise routine that has a lot of different things. We've probably done this for ourselves. ChatGPT is or AI is a great way to get this done if you don't have an easy tool with you. You just say, give me this exercise plan, and they can just spit it out to you. And it's a great, my son and I have also both do that with certain needs. Um, it's really helpful if you have a buddy. Rewards are really helpful. Integrate your exercise into your routine. An example of that would be taking the stairs, right? You want to uh, attain a target heart rate that is calculated. So you can plan for that, right? Like for instance, I am training to get in a better anaerobic place with shape, and so I was looking at what my target heart rate was, and I was running somewhere around 140, and it was right in that range, and I was like, okay, great. So that must be as hard as I'm making progress that way. And you can do that for your patients. You can take them through that. Obviously, they're not going to be at a very high level of their target heart rate, but the more you can do things like choosing a comfortable time of day, or just kind of preventing discouragement. The whole like no pain, no gain, or something like that's probably not going to be a good way to go. Okay, so a successful exercise routine is like we talk about SMART goals, right? Like, okay, is it sustainable? Is it measurable? Is it achievable? So not all physical activity has to be exercise. Sometimes when I was younger, I used to laugh at people that count their steps as exercise. But I'm telling you, when you get older, you don't have as much opportunity, or at least it's not in your priority. So those steps sometimes are a lot more than they've done. So that's a step in the right direction, no pun intended. You're going to want to get yourself the right equipment. So if those are shoes and you're wearing your dress shoes, probably want to get some new ones. Although the other day I was at practice and I saw a kid who I was running with him too, and he was wearing Crocs and he was beating me in a foot race. So, I don't know. I wear good running shoes though. You want to stretch and warm up before you start, and you're going to try to maintain the exercise if you can for a long period of time. That might be 30 to 40 minutes ideally, but any kind of progress is a good start. And then you want to alternate so people don't get bored. And of course, you want to make sure you're hydrated, particularly for someone who has some sort of compromise from a health standpoint. Okay, so for us, so healthy people regularly shift, right? Unconsciously, we talked about this to maintain comfort, but some people are unable to move without assistance, or they are impaired, so their body isn't helping them do that. So they require a change in position at least every 2 hours. Some hospitals require every hour, to prevent skin breakdown and muscle discomfort, atrophy, nerve damage. And so these people are more prone to pressure injuries. And that's because of the pressure reduces the circulation and impairs the oxygen exchange to any tissues or things like that. Okay. So these devices need to maintain, these are around to maintain body alignment. And it's really important. I've talked to you before about legal cases, and I see several of these types of cases where the required turning and things like that weren't adhered to because the nursing staff was either busy or didn't adhere to the policy. And so those are a problem I see nurses running into all the time. Using range of motion and also incorporating things like pillows and wedges. There are special beds, and you'll get to know what these protocols are as you get to the hospital. Okay, so let's talk about positioning. You know what Fowler's is, right? So it's a semi-sitting position where the head of bed is 45 to 60 degrees. All right, so this is a good one because it helps promote respiratory function, and it lowers the diaphragm to allow chest expansion. So a variation of this is semi-Fowler's, which it's about 30 degrees up. So these are 30 degrees is what you will typically see people, because 45 to 60 can be very high for comfort, but you might find them there. And then high Fowler's is where the head is all the way up 90 degrees. Okay. As far as the position that's called orthopnic, the head of the bed is elevated 90 degrees, and then there's an overbed table with a pillow on top of it. And so the patient leans forward, resting on their arms and the head on the pillow. So this is helpful with a patient with shortness of breath. You might also help. You might also find this position used with an epidural, right? But when they're putting their weight on an overbed table, you want to make sure that that's not going to collapse or anything like that. Make sure it's safe. And then the lateral position, it's a side lying position where your top hip is and knee is flexed and then placed in front of the rest of the body. So this creates pressure on the lower scapula, the ilium, and the trochanter. So, but it relieves pressure from the heels and the sacrum, right? So you turn them on their side. So you just have to understand there's pressure being put on the bony prominences on the bottom side, and then what it's relieving, which is someone laying on their back all the time is going to have probably the most pressure on their hips, right? So you just think about that. Lateral recumbent is side lying with the legs in a straight line, and you'll see this in your book. And then oblique position is an alternative to this, and it places less pressure on the trochanter, but patient turns on the side and the top hip and knee is flexed. However, the top leg is placed behind the body. Okay, so check your book out for some of these pictures. It'll make it a little bit easier to understand. Explaining them is sometimes a little bit abstract. And then you have the prone position. So the patient lies flat on their abdomen with their head turned to one side. So this is the only position that allows a full extension of the hip and knees. It also allows secretions to drain freely from the mouth, and so it can help with an unconscious patient. Okay. And then a semi-prone position that is called SIMS is where the lower arm is positioned behind the patient and the upper arm is flexed, kind of like this, right? And so the upper leg is more flexed than the lower leg, and this creates drainage from the mouth and limits pressure on the trochanter. It's an ideal position for administering like an enema or some sort of perineal procedure. Okay. And then the supine position is also called dorsal recumbent. This is a patient lies on their back with their head and shoulders elevated on a small pillow. The spine is aligned and they comfortably rest at their side. In the operating room, you'll see a lot of these positions are very important, and studying what those pressure points are is a major issue that they think about. And it's very easy if you miss one of those prevention techniques to create nerve damage in the patient. Okay, so if you want to move somebody up in bed, frail patients aren't going to be able to move themselves around. So they'll slide down in bed, especially when their head is up. So that can sort of put that slide. It also increases skin breakdown because then you create shear. So you can always help them move independently, but if you have to move them up, you can move with two people. If you want to turn them in bed, you can do that pretty easily by yourself. And that's super important to prevent the patient's skin damage. Pillows and stuff like that can be used to position the patient as well and are very helpful. And then we learned in clinicals about log rolling. So this is just a technique that we use to help people roll. And then we can do that by ourselves potentially to change a bed or even just to reposition them. Okay. So you're going to help the client out of bed. We always use a transfer sheet or a transfer board, some sort of device, right? So the roller is a low friction fabric sheet that's placed beneath a draw sheet. And so you can move from one side to the other. And sometimes what we'll do is we'll put somebody on a stretcher and we will transport them between units. And you see a picture of that here. And then we slide them from one to the other. Obviously, we want this to be safe. We want both beds to be locked so that they don't slide anywhere. Using a transfer board, the reason those are required, but the reason we do that is it reduces the risk of injury from the nurse and also of the patient who can be skin can be damaged during that situation, right? When you transfer them, you want to make sure that underneath there's all the items that all the folds and stuff like that are very flat. Okay, so you'll see this. This is kind of interesting. you might see in the hospitals, a lot of them have installed mechanical lifts at the bedside. So you might see somebody using a Hoyer lift, which is the crane. We have those in the back of the classroom. Or a mechanical lift might even be something that they can be lifted at the bed so that they can do bed changes or give some pressure off certain areas. And then what you're looking at here is what you might call a standing assist device. So this could be used for people that either don't have full full strength and can't do that, or even people that have suffered catastrophic injuries. It can allow them to be upright and mobile, and can reduce the chance of atelectasis and all that kind of stuff, and reduce the chance of deconditioning as well. You'll see the physical therapist use a transfer belt. We use those too. It's really helpful in case somebody falls. You can keep them. It's like having a couple handles on there, right? And it's pretty easy to use. It's very helpful because it prevents them from sliding down. And once they get below you, it's going to be really hard to prevent somebody from hurting themselves. Okay, so when you assist with ambulation, some of the things you're going to have to be thinking about is people that have been in bed for more than a week. They're already going to start to decondition, and so you're going to have to consider these things. So in bed, you can do leg drills. You can do like quadriceps and gluteal drills by lifting your butt off the bed. You can do some of the isometric stuff we talked about earlier. Arm exercises. So you can, if you are getting out of bed, you're using your arms, but if you are able to use your arms, you can help yourself scoot up. You can do, maybe you get the hand squeezer type thing. You can do some of those other exercises with like exercise bands. I've seen people use those. Those are all good ideas. And then even dangling off the bed can be helpful for your limbs. And then if you do have assistive devices, obviously, we'd want you to use them if possible. Okay, so the basics for this care, and then we talk about thinking, doing, and caring. Thinking, the theoretical knowledge is what we're talking about here. The sound base gives you the ability to teach and also encourage the chance that they're going to have the knowledge and therefore be motivated and not overwhelmed by what to do, right? So you also want to help the client critically think through what this might look like. People that come in for a total knee replacement, even though they went through a class and everything else, a lot of times it hasn't gotten through their head that they're looking at a pretty lengthy recovery, especially like a hip replacement. So these types of situations, they might not have thought all the way through. And so you can help them before they get discharged and get surprised by something. All right. And when you're working with the client, as far as the doing, you want to discuss some of the needs to have these strong muscles and why they're going to need to be ready. Okay. And you can also assess their knowledge during this time and try to meet them with a solution and set goals and things like that. Okay. And make sure that what we're doing is responsive to what we're seeing, right? We don't come in there with preconceived notions and push our desires onto them, right? We need to be able to meet them where they're at. Okay, and the last slide. Sorry, I went too fast. So the basis for safe, effective care is thinking, doing, and caring. You're caring for an older client who needs assistance to ambulate and change positions in bed. When preparing to ambulate, the client refuses to use the prescribed cane. What should you do to support the client's safety and psychosocial needs? What are we going to do? Okay, so some patients consider the use of eggs as a sign of weakness or inconvenience and resist using them. However, most people fear the resist the loss of independence. So you can promote the use of these aids by stressing their value and mobility and maintaining independence. I see that a lot myself is when somebody is about to lose independence, they get scared and they react strangely, as something you might not expect. I also had a friend that died a little while back, but as he was getting older, he went on a cruise and they got him a scooter and he was just off and running, right? And so he enjoyed that cruise because he had so much mobility and, he got to go to the casino or whatever he wanted to do. So That made a huge difference for him because he was able to be mobile. So keep that in mind, right? That's going to affect their quality of life as well. So I hope you've enjoyed this. We're going to end here, and then we'll move on to our next lecture, which is assessment of the musculoskeletal function.